name is Alfreda, I'm a student with Jacksonville State University, and today I'm going to be addressing and presenting to you diabetes mellitus, okay? All right, prior to us starting, I've already given you your pre-test, and so we're going to move on into our lecture, okay? Our learning objectives for this PowerPoint will be defining diabetes, identify risk factors and symptoms related to diabetes mellitus, explain the effect of diabetes on other systems in the body, identify laboratory testing related to diagnosis of diabetes, distinguishing between the two types of diabetes, recognizing medications used in the treatment of diabetes, explain the nutritional need of patients with diabetes, and also explain the nursing care of patients with diagnosis of diabetes. First of all, before we move on, do any of you have personal knowledge of someone that has diabetes? Okay. For me, I also have a personal experience with it. I have family members who have diabetes. Currently, I have an uncle with diabetes, and because he has diabetes, he's had to have amputations, because what happens when a person has diabetes, it puts them at risk for other disorders, and he has chronic kidney disease in addition to peripheral vascular disease, and that is what led to him having amputations. So there's a personal connection for me with this particular disorder. Why do you think, as future nurses, that having knowledge about diabetes, why is that important? Right, and you all need to be able to know how to treat your patients, about the disorder, what you're going to do as a nurse to care for your patients that have diabetes, okay? All right, what is diabetes? Diabetes is a major health problem, and it's the 7th leading cause of death, and it's increasing in individual risk of developing heart disease, renal disease, blindness, amputation, and complications during pregnancy. It is estimated that 30.3 million people in the United States have diabetes. That's a lot of people. Diabetes is a chronic disorder characterized by impaired metabolism and by vascular and neurological conditions. A major feature of diabetes is hyperglycemia. That is what we call high blood glucose. Blood glucose is normally regulated by insulin, which is a hormone produced by the beta cells in the islets of Langerhans, which are in the pancreas. Endogenous is the insulin that our own bodies make, and exogenous is the insulin which is obtained from outside sources where we have to administer insulin to a person. Right here on this slide, we have a picture, image of the pancreas, because the pancreas is a major organ that plays a part in diabetes. So I want you to know the anatomical location of it, within our bodies. It lies behind the stomach. The pathophysiology of diabetes. In type 1 is an autoimmune destruction of the pancreatic beta cells, the site of insulin production. It can result in total loss of insulin production. A genetic predisposition and exposure to a virus are factors which lead to and contribute to type 1 diabetes. Type 2 is the pancreas used to continue to produce some endogenous, which is self-made insulin. However, the insulin that's produced is not sufficient for the needs of the body, are not adequate enough for use by the tissue or by both. Another patho of diabetes is the glucose metabolism. Glucose is used for fuel for energy. Glucose is used from the muscles in our bodies and for body tissues. It is stored in the liver and the muscle as glycogen. With diabetes, you're going to have hyperglycemia. Little to or no insulin is being produced. The fat and proteins are metabolized. When the insulin is absent, glucose cannot enter the cell, so it remains where? In the bloodstream. So we're going to move on to the types of diabetes. Type 1, previously called IDDM, which is insulin-dependent diabetes. It's the absence of endogenous insulin. It's formerly called juvenile onset diabetes, and it's the most common found in juveniles and young adults, but it can also occur in middle-aged and older adults. It's an autoimmune process triggered by viral infections, which be caused by the destruction of the beta cells, developing insulin antibodies, and production of the islet cells antibodies. Affected people will require exogenous insulin for the rest of their lives. Okay? Type 2 diabetes is referred to NIDDM, which is a non-insulin dependent diabetes. It characterized by inadequate endogenous insulin and the body's inability to produce insulin properly. The beta cells respond inadequately to hyperglycemia, resulting in chronic elevated blood sugars. It's most commonly found in adults, but it's increasingly found in children. It's controlled by diet and exercise, and it also requires oral hypoglycemic agents or exogenous insulin. For our gestational diabetes, which is found in women during pregnancy who have a glucose intolerance for the first time during pregnancy, but after the baby is delivered, it soon resolves. Our risk factors. Obesity is a risk factor of diabetes. Sedentary lifestyle, family history of diabetes, being age 45 and older, and a history of gestational diabetes. Why do you think obesity? Because the increase in the weight, right? A sedentary lifestyle meaning they're what? They're not getting out, they're not exercising, they're not physically active. And a family history, it can run in families. Age 45 and older, as you know, as we get older, we tend to be more predisposed to developing disorders. Mothers who birth babies that are larger than 10 pounds. Ethnicity, African Americans. We have a 33% higher rate of developing diabetes. Latin Americans and Hispanics, they have a greater than 300% chance of developing type 2 diabetes. Indian Americans, they have a 33 to 55% higher risk of developing diabetes. Also, cardiovascular disease and hypertension. You have your polycystic ovarian syndrome and the presence of asclerosis nigra, which is a skin condition, which is in the darker skinned person, where they have the very red patches in the folds of the skin. Some signs and symptoms of diabetes. For type 1, we have glycosuria, which is glucose in the urine, polyuria, which is increased urine volume, polydipsia, which is increased thirst, polyphagia, which is excessive hunger, weight loss, weakness, and fatigue. Moving on to type 2 symptoms, we still have the 3 P's, which is the polyuria, polydipsia, and polyphagia. But in addition, we have fatigue. The person may have recurrent infections such as UTIs, increased weight gain, prolonged wound healing where they don't heal as like you or I would heal, and they have visual changes where their vision is changing on them. They can develop, glaucoma and other disorders. Some complications of diabetes. Diabetes is the leading cause of adult blindness, end-stage renal disease combined with cardiovascular disease, high blood pressure, and diabetes contributes to end-stage renal disease where the person will eventually go into renal failure and may have to have dialysis. You also have your non-traumatic lower limb amputations, as I said before, to develop peripheral vascular disease, and as a result of that, they will have to have an amputation, whether it's of the toes, legs, however, wherever the circulation is no longer adequate at. Major contributing factors of diabetes is heart disease, strokes, hypertension, and peripheral vascular disease. For the diagnosis of diabetes, what is that normal fasting glucose? Good. Patients who meet certain criteria on 2 separate occasions are considered to have diabetes. Those that have a fasting glucose level of greater than 126 at least 8 hours after fasting. Those with the hemoglobin A1C of greater than 6.5%. How is the A1C measured?
Over 6 month period.
Okay, and what that does is give them a total of all the ranges of what their blood sugar's been running and how the doctor is going to be dosing them and looking at them. Symptoms: polyuria, polydipsia, polyphagia, unexplained weight loss, plus a random blood glucose level of greater than 200. Then you have your 2-hour postprandial glucose level, which is greater than 200. Doing the oral glucose tolerance test, where they use specific guidelines, and And this test must be a low test with the endogenous glucose dissolved in water. And that's about 75 grams. Okay, with your oral glucose tolerance, how this test is going to be given, it's going to provide a diet of 150 to 300 grams of carbohydrates for 3 days prior to taking the test. The night before the test, the person is going to be what? Fasting. Okay, the morning of the test, the blood draw is going to be done for the glucose. The patient will have to be given a drink of glucola, which is about 75 grams of carbohydrate, and they are instructed to remain quietly during the test. Blood draws for 30 minutes to 1 hour after the ingestion of the glucose, and after all the samples are taken, the blood is drawn for hour intervals until the test is completed. Okay? Laboratory testing. Normally there's no detectable glucose or acetone in the urine, but with people who have diabetes, they both can be present. Some blood tests and urine tests that must be done, but the blood test is the most accurate. You have some tests called the DUA, which is diabetic urine analysis test, the urine test for glucose, the urine test for ketones, and you have the lab blood test, which is the most accurate, which is normally time taken fasting, meaning that it's before the patient had anything to eat. You have your ketone and your chem strip blood glucose levels. Then you have your SMBG, which is your self-monitoring glucose. You have the glucose tolerance test, which the patient receives a high, like I say, carbohydrate diet prior to the test, and the person is given a chemically prepared drink, which is the glucola. Okay, medical treatment. Medical nutritional therapy is important in diabetic management and should be included in the self-management education. These are some of the goals of the medical nutritional therapy. First, we're going to maintain metabolic outcome, which is a normal glucose, lipids, and blood pressure. We're going to prevent or slow the development of chronic complications of diabetes, such as obesity, dyslipidemia, cardiovascular disease, hypertension, and neuropathy, by modifying the nutritional intake and the lifestyle of the patient. We're going to consider their lifestyle, personal and cultural preferences when it comes down to meal and nutritional preparedness for them, and whether they have a willingness to change. We're going to limit the food choices when indicated. You have to give them options and involve them in making their diet. At all times when you're having to set up a nutritional plan for them, you need to have a registered dietitian in place as a part of the diabetic management team, so they can work with the individual and also include the individual in the decision-making process about their nutrition. As you can see, this is nutritional management. You're going to be counting carbohydrates. It's useful for people using intensive insulin therapy or the insulin pump. You're going to have create your plate methods. Like you say, you have your fruits, your vegetables, your grains, your protein, and your dairy. All of these have to come together in order to make the patient have a good overall nutritional plan. Exercise. Why do you think that exercise is important? Do we all need exercise? Yes. Okay, so exercise is the most effective treatment with people with diabetes. It aids in what? Weight loss, cardiovascular conditioning. It improves the insulin sensitivity and promotes a sense of what? Well-being. By exercising, the individual will use glucose at a 20 times the rate of the muscles at rest and do not require insulin, so it helps with them to exercise. It improves circulation and helps to metabolize the carbohydrates. So if you're going to be encouraging your patient to exercise, you need to tell them to at least exercise 30 to 60 times, 30 to 60 minutes per day, at least 3 to 4 times a week, okay? Self-monitoring. It enables decisions regarding diet, exercise, and medication, accurate records of the glucose, whether it's going to be fluctuating or not. It's going to help to identify the episodes of hyperglycemia or hypoglycemia. It's going to help you maintain your glycemic goals. It's a must for people who use insulin. They must monitor their blood glucose level, and the frequency of tests varies. Sometimes you can take it in the morning, in the afternoon, depending on your doctor recommendation, you have to take it before and after meals, or either 4 times a day. And you can see that on different physician orders. What you're going to do with the glucose monitor is you're going to be doing patient teaching. You're going to teach them how to use it, how to calibrate the machine, the glucometer, so they can make sure that their results are accurate. When to test: before meals, 2 hours after meals, when a hypoglycemic episode is suspected, before illnesses, and before, during, and after exercises. This image right here is a picture of a glucometer. There's a variety of different brands, but they all serve the same purpose. The patient used these to keep track of their glucose levels. And like I say, you have to calibrate them to make sure that they are giving out accurate readings. So that'll be another thing as a nurse that you'll be doing with your patients. Treatment, such as drugs, insulin. Insulin is an activated process that helps the glucose molecules into the cells of striated muscles and adipose tissue, and it also stimulates the synthesis of glycogen by the liver, which produces protein synthesis. With insulin therapy, you have the type 1 diabetes patient need insulin injections. Some type 2s may eventually require insulin also. Insulin is classified by its source and its course of action. The source, you have your human, your pork or your beef. You have a course of action where they are rapid acting, that's your humalog, your novolog. Your short acting, which is your humalin R, your novolin R. Your intermediate acting, which is your humalin N, novolin N. Long acting, which is your Lantus, Levemir. And then you got your ultra long acting, which is Tadalol. All rapid acting and short acting insulins are clear. Other insulins such as are clouded except for your Lantus and your Levemir. And insulin is measured in units, it's given in units. Insulin therapy, routes, oral. Insulin cannot be given orally due to the gastrointestinal tract. It breaks it down. Subcutaneously, insulin is given by this route most of all the time, and intravenously, only regular insulin can be given that route. Your phases, onset, is when the insulin begins to act on the body. The peak is when the insulin is exerting its maximal action, and the duration is the length of time the medication is to remain in effect in the body. Okay, this slide right here, this recommends, it's the different types of insulin. As you can see, it has rapid acting, the onset, the peak, and the duration. It's just a chart guide that you can use to look at the different types of insulin and look at how the time that they onset, the peak time that they are at their maximum point, and the duration of how long they're going to remain in effect and doing their action. Insulin pump. Have any of you ever seen an insulin pump? Okay. It's another form of insulin therapy. There's a needle that is inserted subcutaneous into an appropriate site on the skin. The pump is programmed to deliver a steady trickle of insulin throughout the day, and it can provide a bolus of insulin at mealtime. This is something that I've seen some people do. They eat a lot of this sugar, and then to fit their need, they'll bolus themselves to address their blood sugars, make sure they don't be running too high. With this insulin pump, it has a needle, a syringe, and tubing, which has to be replaced every 2 to 3 days. The insulin pen, I actually bought one of these. I don't know if you all have actually seen them, which y'all been going to the clinic, I'm quite sure. You all have seen an insulin pen before. If you would, pass it around. And you can let everyone see. And what happens is you have a little needle that goes with that you attach to it and give to the patient. You have to have your alcohol prep, your insulin pen, and your needles, and you will dial up your dosage per the MD order, and that's how you administer it to your patient. There's a different variety of insulins and the way that it's administered. You also have your vial insulin. This is a vial of Lantus, and you have your insulin pen, needle that you also can use to give patients their medication. And as I say, it's just a visual of to let you know the different types, okay? Insulin injection sites. These are some of the injection sites that you can use to give a patient their insulin. You have your upper outer arms, your buttocks, your abdomen, and your upper outer thighs. These are some good sites to use. Insulin issues, problems that you will more than likely have with insulin, some complications of hypoglycemia. It's like this, once you give insulin, you can't take it back. So a lot of times, if you give insulin, that's why it's so important that you monitor your glucose level, because it can actually, lower a person's blood sugar real low. So with hypoglycemia, you have low glucose levels. The patient can experience shakiness, nervousness, irritability, tachycardia, anxiety, lightheadedness, hunger, tingling, or numbness of the lips or tongue. The patient needs to keep hard candy with them just in the event that they have an episode of hypoglycemia. The patient can have allergic reaction, they can have itching, arrhythmia, or burning at the injection site. They have lipoatrophy, is a hollowing or pitting of the subcutaneous tissue, lipohypertrophy, which is a swelling or a lump that would develop on the skin, and that's due in part to them failing to rotate their sites. Okay? All hypoglycemic agents. They act by stimulating the beta cells of the pancreas to produce more insulin. They can only be used when the pancreas is secreting some insulin. Type 1 diabetics cannot take oral agents because these drugs are not what? They're not insulin. You have side effects such as hypoglycemia, nausea and vomiting, headaches, hunger, weakness, and drowsiness. If the serum glucose stays elevated, insulin may be given temporarily until the glucose is decreased down to below 200. You have your second generation, your sulfonylureas, so glucoside, glucotrol, glucoside, dibeta, Amaryl. They're most potent, but they have fewer side effects. Other medications that you may have is metformin, Fortimate, Glucophage XR. They do not cause hypoglycemia because they have decreased glucose production in the liver, but they increase glucose by the muscle cells. Okay, nursing care related to diabetes. You want to do a physical examination. You want to assess your patient level of consciousness, posture, gait, your overall well-being. You need to monitor the patient's vital signs. You need to also assess their height and weight. You need to assess the glucose level for hypoglycemia or hyperglycemia as ordered. You need to administer your medications per your MD order. Your diet, they're not supposed to have any concentrated sweets, and also the patient may need a diabetic snack. You need to monitor your input and output. You need to assess the patient for dehydration. You need to encourage exercise. You need to check the blood sugar before, during, and after. You need to assess the skin daily. Why do you think you need to assess the patient's skin?
Because sometimes diabetes hit.
Right. So you need to look for what kind of areas. Open areas, blister formations, infected wounds. You need to look if your patient do have a wound. You need to be looking at to see, okay, is this wound healing? Because if the wound is not healing, it's delayed, and those are conditions that need to be reported to the WHO, the doctor immediately. You need to review your labs and notify your physician of any abnormal values. Going with these patients, they're going to be looking at the glucose level, they're going to have fasting level, and they're going to be looking at the hemoglobin A1C. Any abnormal results, they need to notify the physician, because this is how the doctor is going to be adjusting their dosage of medication. So patient teaching. If your patient is going to be going home, if they're in the hospital, or either they're in the long-term care setting, you're going to educate the patient and family on the signs and symptoms of hypoglycemia and hyperglycemia. Glucose monitoring, the glucometer, you're going to tell them how to use the device, how to perform calibrations, how to collect their blood samples, and how to discard their lancets. You're going to also prepare the patient and the family on how to use the oral glycemics or the insulin. You're going to teach them how to use it, and then have them to return demonstration that they know how to properly give themselves the injections, how to store insulin. You need to tell them how to store the insulin. Educate patient and family on the proper techniques of drawing it up and giving injections. You need to explain to them the importance of rotating sites. If they don't rotate sites, what could happen? Right, and you just talking to them about the diets. They need to follow a strict diet. They need to do a diabetic diet. They don't need to just eat everything that they can possibly eat. They need to stay, as much as possible on the diet that the doctor has prescribed for them. Good skin and foot care, right? Okay, shouldn't they be seeing a podiatrist kind of often, because the podiatrist need to be looking at their feet, and they need to check their feet when?
Every day.
They need to be looking at their feet daily to make sure there's no changes, no cuts. Do they need to walk outside with shoes on? Right. They need to be making sure they do meticulous foot care. You need to encourage them to follow up with dental checkups and also routine eye exam, because changes in your vision can be identified early on. So if you have some problems, it can probably potentially halt some of them. Okay, this slide right here, you can look at it. It's the hypoglycemic and hyperglycemia. And I have symptoms on here that you can use to educate your patient on. As it says, causes too little food, too much insulin or diabetic medication or extra activities. The patient can have symptoms for hypoglycemic, shaking, fast heartbeat, sweating, dizziness, anxious, hunger, impaired vision, weakness, fatigue, headaches, and irritability. What you can do when you have someone that is hypoglycemic, you need to be giving them something to try to what? Bring their blood sugar back up, okay? Hyperglycemia, which is high blood glucose, too much food, too little insulin or diabetic pills, illness or stress. You can have symptoms of excessive thirst, need to urinate often, dry skin, hunger, blurred vision, drowsiness, and slow wound healing. So all of these are signs that you need to be calling the doctor immediately so you can get a change in the plan of care for them, because some sort of way they're not being managed, okay? All right, so now we're down to the post test, which is about 3 questions I got you all to answer here. So my question is, a client who is started on metformin and glipizide would have initially presented with which type of symptoms? You have your choice of A, B, C, or D. A. So you believe A is the correct answer. Okay. Okay. A is called polydipsia, polyuria, and weight loss are symptoms of what? Hyperglycemia. That's right. And those medications, the metformin and glipizide, are what? Oral agents. Okay. Next question. Which type of diabetes is controlled primarily through diet, exercise, and oral anti-diabetic agents? Type 2. That's right. Because that is how that is primarily treated, correct? Okay. Next, our last question is rotating injection sites when administering insulin prevent which complication? B. That's correct. Okay. All right, this is a reference. My references came from your textbook. You can find this information I presented today in your textbook. So I just want to let you all know, thank you again for allowing me to come in and to present to you all today. And if there are any questions, we will end my portion of the lecture right now. Thank you.